Welcome to 94th Stanford MedAI Group Exchange session. This week we have Monica Agrawal from Duke University here with us to talk about her work on scalable NLP for transforming medicine. Monica is an incoming assistant professor at Duke University, as well as the co-founder of a new health technology startup. In her research, she tackles diverse challenges, including scalable clinical information extraction, smarter electronic health records, and human-in-the-loop systems. She recently earned her PhD in computer science in the clinical machine learning group at MIT, and previously she obtained a BSMS in computer science from Stanford University. So, Monica, thank you very much for joining us today. Before we start, do you have any preference on how you would like to take questions?
Yeah, I think any short questions that are sort of factual about the current material is fine to interrupt me with. And then I think any longer questions that are more of a discussion, we can hold to the end.
Thank you very much, Monica. So everyone, without further ado, let me hand it over to Monica.
Thank you. Great. I assume you can see this okay?
Yes, we can.
Great. So I'm Monica, and this is describing work I did during my PhD at MIT, and I'm about to be moving over to Duke. So as people in this audience likely know, electronic health records contain a wealth of patient data. And they've seen rapid adoption in the United States, going from 28% in 2011 to 96% adoption in 2021. And with that adoption comes great potential. So the real-world evidence found in electronic health records can help facilitate personalized medicine, since clinical trials alone can't answer every question. For example, what drug would lead to the best outcome for this specific patient with, for example, specific comorbidities and past history? What's the patient's expected disease trajectory based on what we've seen of their disease so far? And what adverse events might come from a certain drug combination, since in a trial, this could lead to combinatorial explosion. So let's say we wanted to answer the question of what drug would lead to the best outcome for this patient. What variables might we need to be able to carry forward something like this? First, we need to know what disease the patient has. We might want to know their status and how that disease status has changed over time, so we know where they currently are. We might need to know what set of interventions they've already previously tried, as well as symptoms and side effects that they've had to potentially understand what they might not react well to, as well as other confounding factors like other diseases they might have that might affect what treatments they may or may not be eligible to get. So the challenge here is that many of these variables are not found in structured data, but they're instead trapped in messy free text clinical notes. And this is for a few different reasons. The first is efficiency of documentation. It's a lot quicker to write something in free text than have to click a bunch of disparate boxes. Second is because of splintered care. So a patient often doesn't get all of their care at a single institution. So potentially a previous event may have occurred at hospital A, and now they're being seen at hospital B. So the only mention, we don't have the structured data from hospital A, but they might have mentioned it and it's included in a note. And finally, deviation from original care plan. So you might think that things like what medications they take, we can pull solely from structured data like pharmacy records. But in reality, what's often most important to capture in medicine is not what was intended, but when there were deviations. So for example, a patient might be prescribed a medication for 6 weeks, but they might only take it for 2 weeks due to really bad side effects. And that's something that's really important to be able to capture in our data set and would be described in text potentially, but not in the pharmacy records. So a question I often get is how messy can clinical notes be? And the answer is very messy. So often if you look at a note, it might look something like this. So if we wanted to decipher this clinical text, there's a few steps we would go through. We would first try to kind of expand all of the jargon here. So for example, 5 Mos to 5 months, carbotaxol to the combination carboplatin paclitaxel, EC to endometrial cancer, etc. And then we have to understand what kind of goes with what. So here it says we'll discontinue the carbotaxo for the pembrolizumab. And even though discontinue is in the same sentence as pembrolizumab, it's actually referring to the previous medication, and the pembrolizumab is being started. And now once we have that, we can start to build this timeline of what's happened to a patient so that we can begin to do better treatment understanding. However, this is a daunting task. A patient can have hundreds of notes that need to be structured in order to kind of create this timeline of what's happened to a patient. And if we want to compare this patient to past patients to determine their optimal treatment pathway, we might have to compare to thousands of past patients to find patients that were similar. So you can see how this could be a really daunting task. So the status quo in medicine right now to get from unstructured clinical notes to structured data that's usable for medical research has largely been to do a full manual chart review in which you get a team of clinical professionals who know how to parse this jargon and go through the steps to manually understand what happened to a patient. In the last 10 years or so, the paradigm has shifted more towards doing a more partial chart review followed by a machine learning or NLP model and using that to feed into the structured data. And in my early work, that's a lot of what I did. So using clinical notes and partial chart review plus this machine learning NLP model to get to the final answer. And this was in kind of a variety of hospital and industry settings. And what we found was in doing so, we could recreate the survival analyses achieved by full chart review. So we got indistinguishable results, but we only had to annotate a fraction. However, this partial chart review is still a huge bottleneck. So it's variable and setting specific. So for each variable, you need your own data set. And the way things are described are different from hospital to hospital. And second, this still requires a huge amount of initial annotation time. Finally, this is increasingly difficult because it's difficult to share clinical note data across institutions. Compared to things like clinical images, like X-rays, notes are incredibly sensitive and therefore much harder to share. So what my research has consisted of is how can we do clinical NLP scalably? And I've approached this from a few different angles. So one is how can we optimize the annotation effort we do have via human AI teams? How can we design models that better leverage unlabeled data? How can we leverage large language models more recently? As well as finally, how can we actually incentivize cleaner clinical documentation in the first place? And in this talk, I'm going to kind of give short vignettes describing each of these. So first, I'm going to talk about how can human AI teams speed up clinical annotation, very briefly. So in this paradigm, what we're trying to think about is how can we replace one of the human annotators with an AI decision support to speed up the process. So the problem we were tackling here is clinical concept recognition. So for example, you're given a sentence, and as I showed before, the very first step is understanding for each different mention, can we normalize it? So understanding what concept it refers to, so that PT refers to patient and not physical therapist, and that carbo refers to carboplatin and not carbodome, a different drug. And the things that make this difficult is that there's many labels that you need even for a single sentence, and that the label space is incredibly large. So there's over 400,000 medical concepts in UMLS, which is a medical ontology. So to make this faster, we developed an annotation platform with built-in decision aid. And the decision aid included things like label recommendations when you clicked on a term, as well as pre-filled suggestions when we were relatively confident. And as an example of the impact, the Broad used the tool in order to label cardiac MRI reports. And in about 11 hours of annotation time for them, they were able to extract 21 measurements and achieve an F1 score of around 0.96. However, I think the part that's really interesting, and especially as we go forward, particularly with large language models, is to think about what is the effect of decision aid on clinicians. So we conducted a user study in which we had 18 clinicians, so either medical students or clinicians from 9 different institutions use this platform for 8 hours each. And the purpose, we had underlying ground truth, and the purpose was to understand how did the decision aid affect them. And what we found, for example, that the recommendations did in fact lead to only half the time needed for label selection. But when we were analyzing the effect of pre-filled suggestions, we found that overall they did better. So their recall was higher. However, on the examples that the decision support missed, they did worse than their colleagues without the decision support. And this is thought of in the HCI community as lost agency. And this has implications when we think about bringing in decision aid into clinical medicine, as we think about how do people react when they're provided with decision aid, and are they able to mediate in errors in AI. So next, I'm going to be talking about how we can design label-efficient algorithms. So the paradigm here is how can we build a model such that we need far less data than before. So the idea is that how can we use only a very small fraction of the amount of labeled data. So the issue generally when you have a very small labeled data set is you have a low signal to noise ratio. So this is because text in particular is a high dimensional input, so you might have thousands of different tokens. There are multiple ways to say the same thing, making it harder. So for example, fever could be febrile or pyrexia or any temperature over 100 degrees. There's a single way to say different things. So PT can mean patient or physical therapy, prothrombin time, or posterior tibial. And MS similarly can mean several things. And finally, there's often lots of irrelevant information. So clinical notes are quite long, and often there's only one tiny piece of information you might need from it. So if we that might be kind of hidden in the larger piece. As a result, when you have a very small labeled data set, it can be difficult to get enough signal. So the way this is generally done is with better representations. So this is clustering word level representations of clinical BERT on the word depression. And here what you can see is for a good representation, you should be able to separate the different meanings. So the difference from the mental health depression from a physical depression to an EKG result. And this can also happen at the phrase level where you learn representations for phrases. And the goal would be that in this representation space, you can easily learn a classifier to separate patients with early cancer versus late stage cancer, or patients with metastatic cancer, patients with stable cancer versus progressing cancer, or on the left, early cancer versus metastatic cancer. So the paradigm here is that you usually start with a high dimensional input that you put through an embedding model, and then once you have a low dimensional representation, use a classifier to answer. So then the question is, how can we learn good representations without any labeled data? So prior work in representation learning revolves around self-supervision, where you leverage the implicit structure of unlabeled data to learn useful representations. So very commonly over the last 5 years, in text, that has involved the masked prediction objective for BERT. And in the masked prediction objective, you take a sentence, you mask a word, and then you ask the model to learn to fill in that word. It doesn't need any labeled data to do this task. It's just based on unlabeled text. But in doing so, it can learn associations, like the fact that warfarin is taken for AFib. However, this masked objective has actually seen middling results in many applications in clinical NLP. So for example, on the top left, we see the original paper where it was able to get a 0.03 AUC bump. But in many other works, there's often little to no benefit from this added complexity over something like a random forest or a logistic regression. So then the question we have to ask ourselves is, when we're doing this dimension reduction, does the representation actually recover the signal that we care about? So what my work was looking at was how can we conduct grounded self-supervision for a chronic disease. So the example task here is identifying cancer progression. So what this is when a patient gets, for example, a CT scan or an MRI, they look to see whether the patient's cancer has progressed or gotten worse. And what this is useful for is understanding whether a medication worked or not. So it's a common reason why a patient switches medication. And it's important to understand why a patient stopped a medication and whether it was disease progression or, for example, symptoms. So the intuition you should have here is that what we're doing is leveraging temporality. So let's say you have a set of longitudinal clinical notes for a single patient that are ordered in time. So the very light notes on the left are the earliest notes for the patient, and the darker notes on the right are the later notes. The question is, what if we then scramble these notes so they're all mixed up? Can the model learn to reorder these notes? And this is something we named order contrastive pre-training. And the instantiation of this is unscrambling consecutive pairs of notes. So what we do is we train a representation to predict if a pair of notes is in the correct order or in the wrong order. So below you can see the first and third are correct because the first note is lighter than the second, and in the second row, it's in the flipped order. And the intuition here is that we want to do a dimensionality reduction to what we call the time irreversible features that really signal disease progression. So to make this clear, let's have an example. So in note 1, it says impression unchanged bone mets, follow up in 3 months, recommend PT. And note 2 says impression since last scan, no evidence of metastases, follow up in 3 months. For those of you in the audience who might be clinical, you can take a second and figure out which note came first. So in this set, if you have kind of a clinical background, what you would find is that note 2 occurs before note 1, because note 2 says no evidence of metastases, and note 1 indicates that there were existing metastases, but these are unchanged. And the clinical piece of knowledge that you would need is the fact that once you have metastases, they very rarely resolve. So that note 2 would come before note 1. And this is exactly the sort of information we want to imbue in our model, and not things like follow-up time. So what we want is the low dimensional representation we have to really capture the features that are time irreversible. So we also grounded this in theory, and I'm not going to go heavy on that in this talk today. But essentially, you can think of a note as consisting of 3 types of features in the simplified toy model. The first kind of feature are time irreversible features, things like unchanged bone mets, where once a patient has bone mets, that's not going to likely fully resolve. The second are noisy versions of S. This is things like recommend physical therapy. They don't directly talk about the patient's disease status, but they might be a noisy version of it, because the fact they recommend physical therapy might indicate that the patient is not doing, it needs some help. And finally, there are things that are background features like impression or follow-up in 3 months. And these are features that don't necessarily provide any signal and kind of occur across notes or boilerplate. And what our theory showed was, assuming that what we care about for doing our downstream analysis is the function of only that S of time irreversible features, the model OCP, this order contrastive pre-training where we switch notes, and have it predict the order can discover S with high probability, and that we can lower the upper bound on labeled sample complexity, which means provably you don't need as much labeled data. Now in practice, the only thing that really matters is whether it works on real-world experiments. So we did it in two cases. So first, we looked at the linear case, where the goal was to classify radiology notes. And what we want was to understand if this OCP selection chose good features for linear models. So the steps here are first, we do L1 regression on this ordering task of which note comes first. Then we find which sets of features have non-zero coefficients. So what features and what tokens are useful for doing that ordering. And finally, we only use that subset of features for the downstream task. And what we find is that OCP, in fact, acts as a good feature selector. So if we looked at what words it originally chose, it chose relevant terms to disease progression. So it selected words like mass or increased, stable, suspicious, decreased, and excluded words like discussed, imaging, left, and follow that might just be background words. And that way we can achieve this dimensionality reduction.
So Monica, one quick question that why you didn't use the node generation time for doing this? Like why you need a separate model to understand which node come first, which node come second?
Yeah, so the reason we were doing this is not because we don't know which note comes first and which note comes second. So we have the ground truth for all of this.
Right.
So we have the ground truth of which note is first and what note is second. So the reason we're doing this is to actually learn how to learn what features are important. So
okay.
our goal
okay.
is
So this is like a more for you like I say self-supervision task, right? Like more like learning.
This is only the self-supervision pre-training task.
Got it. Oh, got it.
And then we use it on radiology classification.
So why did you select this task as your self-supervision, not anything else? Because
yeah, I mean, so I think what it was based off of is we were trying to figure out what signal could we use.
Okay.
Since the signal of, masking words often meant that, this is a very toy version of a note that's quite short, but you can imagine normal clinical notes are 500 words. Right. And maybe for a lot of tasks, you might only care about a very small portion of them. So as a result, we might not need a great representation of follow-up, for example, in the same way we want it to really learn exactly the knowledge needed for ordering. So this is really about disease progression and chronic disease. We wouldn't think this would work well for any possible task.
Right. So that was my question, right? Like imagine like this example is perfect when you look for like a cancer patient who has a very regular follow-up on the same thing, right? But if the patients are coming from like random things that they don't have cancer or such kind of like past severe comorbidities, I think this would be a kind of like very difficult task to order the notes based on that if you don't have a severe comorbidity.
Yeah, so I think this is specifically for those cases where you have patients with chronic disease, whether it be cancer, neurodegenerative disease, and I'll get to it in conclusions, but I think part of it is the idea that there might not be one perfect one-size-fits-all self-supervision task, and that you might actually be able to do better with kind of thinking about self-supervision as it directly relates to the exact structure of your data. But I totally agree, it would not work just for random visits to your PCP necessarily that don't kind of correlate to this larger structure.
Okay, got it. Thank you.
Yeah, so in this case, you can see that if you have all of the training data, using only the subset of features found by this pre-training method doesn't make a huge difference, but there's a huge AUC jump of 0.06 when you only look at 1/16 of the training data, which corresponds to about 5 patients of training data, so an incredibly tiny set. So we also did this.
Can I ask a quick question as well, Monica? So in this, how exactly are you doing the feature representation? Is it like are you using a text encoder to actually encode these
This
notes?
is full back-and-forth linear model.
Okay. Gotcha.
And then in
Okay.
the next one, I'll get to the deep. So this is just like you have a bag of words. Which of the words should I throw out? Because they're just going to be more noise than signal.
Gotcha. Okay, thank you.
So the feature selection is done with a huge amount of unlabeled data, and then you can choose a set of 25 or 50 features and only use that for doing your classification.
Yeah, that makes sense. Thanks.
Yeah. So then we also look at the deep setting, where we're looking at, can we learn useful deep representations? So what we're doing here is we pre-train a representation using the transformer architecture to focus attention. And for people who are not familiar with NLP, you can think of attention as sort of a soft weight, where some words get a higher weight than others. And once we pre-train that representation, we just lop off the last layer, which was used for the ordering, and use the embeddings in the last layer as input for the downstream task. And these are the embeddings for the CLS token.
Oh, one more follow-up question, actually. So in this pre-training, do you actually do your OCP pre-training, or is it
This is
like
OCP pre-training. Yes. So this is just
Oh,
pre-training
okay.
it on. So we basically feed in a pair of notes. So
Okay.
here's one note, here's a second note, and it's doing a classification task of which note comes first. And that's the pre-training.
And so the transformer that you're using is actually like pre-trained already, like it's able to get you a representation of a given text paragraph. Is that correct?
The representation we started off with, it might have just been from, yeah, I think it might have just been from a BERT base, if I remember, or it was randomly initialized. I think it was BERT base. If I had to guess, this was like 4 years ago that I did these experiments, 3 or 4 years ago, but yeah.
Okay, yeah, that makes sense. I was
So
just wondering if
these
you had like multiple pre-training things going on. Makes sense.
Yeah. So just a small
Yeah.
question, like
So the
these
pre-training
notes.
Sorry?
So just one small question. These two notes, they're just concatenated one after the other. There is a special token to
The thing, there's a SEP token that's often
stop
used,
token.
and then the second one. So truly, we can use an out-of-the-box representation from like Hugging Face for taking in two notes, which kind of already, so we can use totally out-of-the-box representations here.
Makes sense. Thank you.
And what we find is that,
sorry, how long the note? Like if you can get two notes together, will they very long?
So in this case, since we're looking at radiology notes and just the impression sections, these aren't super long notes. So they're a few hundred words. If you're looking at incredibly long notes, there's now things like Clinical Longformer that allow you to have kind of longer sequence lengths than we did at the time we made this. So yeah, if you have incredibly huge notes, it might be useful to get, there's often one section that contains, for example, some of the, like the assessment and plan section of the note or something like that.
Okay.
That might be shorter if you have, because I think, clinical notes can obviously be like 30 pages. And in that case, it might be helpful to do some pre-processing of the data. And what we find is that we learn good deep representations. So on the left, we have two trained BERTs, one that was just, out of the box BERT, and another that was fine-tuned on this specific radiology data set. And what we see again is that when you have all of the training data, you can do slightly better with, pre-training with OCP instead of something like BERT. But you see huge gains when you use only 1/16 of the training data, corresponding to only data for 5 patients. We can still achieve an AUC over 0.8, whereas the other ones are significantly lower. And we can also look at where is OCP placing attention during this pre-training procedure, and it's the same sort of words that we would expect that correspond to disease progression.
So if probably I missed that point that when you were describing your task, so what was your task here? Classifying the radiology report for progression?
Yes, so, radiology reports for progression. So did the patient disease get worse, essentially. And this is a very common endpoint for a lot of clinical research studies.
So you have 3 class, right? Not 2 class. So you have probably not progressed, progressed, and unstable, right?
In this specific data set, they gave us just progression or not progression. There's other sets that also include like stable, improving, worsening, mixed response, and things like that. Other classification, but in this case, the clinical collaborators we were using had just labeled for whether something was progression, because that was an endpoint they needed.
Okay, got it.
So the third row here, sorry.
I was going to say nothing about this is specific to 2 classes, so it could easily be extended. Continue.
Yeah, so the third row here, is it like you take the original bird that has trained using the mask LM and then further train using your proposed pre-training task?
So the very first row, the OCP, is the order contrastive pre-training from us, and that's the only one using that task. And then the second 2 are just baselines of using masked language modeling. So in one case, it's out of the box masked language modeling, and the second is if you made it radiology specific.
Okay.
But only the first one did we do the order as the pre-training task instead. Cool. So the takeaway here is that we were able to do this disease progression classification with very few labels. And to do so, we leveraged the shape of longitudinal clinical data. And what this really says is, if we go past generic heuristics and self-supervision and really think about the shape of the data that we're dealing with, we can do far better than generic heuristics like masked language modeling. So now I'm going to talk about how we can leverage large language models. So the idea here is how can we sort of almost rethink this whole paradigm and replace these steps with a large language model instead. So the question are, can large language models, which are used in all sorts of ways, also help us in achieving structured clinical data? So the first challenge here is clinical text availability. So at the time we actually wrote this, there was not clinical, there was no way to actually run things like data sets like Mimic through OpenAI. So we didn't have any data on which to test this. So most existing label sets were under data use agreements that couldn't be sent over APIs. I think now it's possible if you get certain agreements to actually use these. But due to patient privacy, there are likely not significant corpora of clinical notes in the training data. So what we did was we created benchmark data sets. So we re-annotated a publicly available data set to release 3 new few-shot extraction data sets. So these were in topics like clinical co-reference resolution, medication and status classification, and medication and attribute relation extraction. And I'll go into what some of these are later. And what we did when we released these data sets was each contained 5 examples for development, so prompt design, and 100 examples for test. The second challenge here is obtaining structured evidence-backed output. So let's say our goal is to get different medication relations. So getting medications and their reason, dosage, and frequency as available. So let's say the input has something like 500 milligrams of metformin BID. The expected completion might be medication metformin, dosage 500 milligrams, frequency BID. However, the thing that we might actually get from GPT might say something like the medication taken is metformin for the reason of diabetes at a dosage of 500 milligrams. And there's 2 issues. One is the fact that there's this narrative format, and the second is hallucinations. So for example, here it filled in the fact that the reason for metformin is diabetes. And while metformin is the most common indication for diabetes, or diabetes is the most common indication of metformin, it's not the only one. And what we might not want is to fill our data set sort of with these inferences that kind of only bolster the most popular class. So what we did was we encouraged quoted structured output. So in the naive approach I just showed you, it would take a lot of effort to go from what's shown in blue, that narrative format, to something that's kind of nice and structured that we can place in a database. So what we do instead, which I think now is a lot more used, is this one-shot quoted example. So at the time, I feel like this was like a year and a half ago, we showed that, you know, if you gave an example, we could actually get it in a really structured format where it was, as shown now in blue, where it's really easy to transform into sort of a JSON format for inputting into a table. By forcing things like guidance. So in this case, it's as simple as a dash. We force it to create a list. And that makes it really easy to do the parsing. And what we found is that we can really do this with very minimal post-processing. And finally, the most important part is what we showed it in the form of quotes. And by forcing it to create quotes, we're able to decrease the amount of hallucination since it has to tie every output to a checkable input in the prompt. So we can verify that it did not get information from a hallucination. And the final challenge, which might be the largest, is deployability. So there are questions of HIPAA compliance depending on the model. There's unwieldy size for many of these models. So there are, you know, 175 billion parameters. It's too large to run a lot of hospital infrastructure. Models can be really sensitive to exactly how you word a prompt. So if you change 1 or 2 words in your prompt, it might kind of shift things around a little. And models are often miscalibrated and overconfident. So you might not be able to trust the probabilities that the models output. And this is when the output probabilities are available, which is often not true for a lot of these commercial models. So then the question is, they're incredibly powerful, but how can we deploy them in a more confident fashion, given that we can't trust the output probabilities? So what we do instead is we treat the LLM outputs not as the final answer, but as weak labels. So to describe what this looks like, let's say you have a set of examples shown here in purple, and we run them through the LLM. And this is something that works for classification tasks. So if we can first get large language model outputs on some publicly available data set, and then each color describes a different class that the LLM might have classified each input as. The second step, which I'll describe on the next slide, is identifying where the large language model is confident. The third is then we can now train a smaller model, something that might be BERT-sized. That's a lot easier to do on, you know, hospital or research infrastructure. But we only train the smaller model on the confident outputs, not all of the outputs. And what we find is that if you run that smaller model on the same data set again, all of them, including where it wasn't confident, it can actually fix errors. And we can also now run it on new data sets like the red data set, which might be private and that you might not be able to send to an external large model. So then the question is, how do we select these confident outputs? Since these deep models are often very overconfident and miscalibrated, how can we determine when to trust their outputs? And this is work that was partially done in ICML and that a lab mate, Hunter Lang, published more in the general domain at NeurIPS last year. So first, you're going to want to embed each example. So this is, you know, each square in our data set with some phi of x. And this can just be, for example, a BERT embedding. And what we want is, and what each color represents here is a different class. So what we then do is we make a k nearest neighbors graph in this embedding space. And now what we want to do is we only select the examples from the homogeneous regions. So for example, this is the region where the LLM always thought the answer was orange, and here's the region where it always thought it was striped. And the idea is, in this region in the middle, the large language model was sort of on the edge, and it could have gone either way. And those might be less confident examples that might have the incorrect label. So if we only select examples from regions in space where the large language model was similar to itself, we can be more confident in those examples. And to define what this is mathematically, we use just a test statistic. So we look at sum of how many neighbors are alike versus how many neighbors we'd expect to be alike if there was a normal distribution. So let's look at some results here. So if we look at a task of clinical acronym disambiguation, the input is a clinical text snippet and an overloaded acronym, something like PT, that can mean multiple things. And the output is a multiple choice expansion of that acronym. So if we look, so in red, there is a baseline from Adams et al. That's a zero-shot baseline trained on mimic data. And what we find is that in purple, this was a GPT version from 2022, we can significantly outperform. But now if we add this confident layer on top in green, we can actually, by subsetting and retraining on just the confident data, this weak supervision procedure can boost our accuracy even further. And then we can also apply it to mimic, which at the time we had no way of running through OpenAI, and we find that we can do even better than something trained on mimic itself. Another example we looked at in this paper was medication information parsing. So the input was a clinical text snippet, and we wanted things like medication, dosage, route, frequency, reason, and duration. And here, compared to PubMed BERT and a CRF, this was a supervised algorithm based on a different clinical data set. We actually found that GPT can do even better with just one labeled example. And these data sets are publicly available on Hugging Face, and there's been some follow-up work from Microsoft with kind of new prompting strategies here as well.
Monica, so all of these tasks, dose, frequency, route, and reason, they're all basically classification-like tasks, like how are you evaluating?
Yeah, so this is based on, you have a snippet of clinical text, and in it, there is, it's a narrative form, and you want to basically get out a list of medications. And for each medication, what was its dosage, what was its route, what was the frequency that they are told to take it. So it's for each token, there could be so we actually, I didn't go into we have it in a few different ways, but it's basically each token has a classification.
Each token has a classification. Makes sense.
But we also do groups, so you can look at, these are phrases that are all grouped together, or we also contain the information of like which frequency maps to which medication and things like that. So you can do kind of a variety of different tasks. So relation extraction or token classification.
Oh.
Yeah. So the takeaway here is that large language models have reasoning capabilities and medical knowledge that could really transform clinical information extraction. But we also developed further techniques to boost model performance, as naive application of these models can often be insufficient. So finally, I'll quickly talk about incentivizing cleaner documentation. So this was kind of joint work with a lot of folks. So I want to call out Divya, Luke, and Sharon specifically, who were first authors on these papers. But the idea here is, the issue is that we're dealing with these really messy clinical notes, and that's why we have to do all of this work. So then the question becomes, can we actually change the documentation process and actually go to before the clinical note is written to get cleaner notes in the first place? So electronic health records have known usability issues. There's a lot of articles like this on how doctors hate their computers. And there's two big issues we're trying to tackle here. One is the time needed for data entry. So it takes a really long time to write notes. And second is the time needed for information retrieval. This is the time needed to find information about the patient that you need in order to do a good diagnosis. So data entry has been hard for a really long time. So this is a 1975 paper on the characteristics of notes, and they call it a compressed type of material, and that entries must be brief to save time and effort. So the fact that notes are hard to read is a very old problem. And what we did was we introduced a solution for streamlining data entry. So this is something that we call the contextual autocomplete. So the autocomplete suggestions here are personalized to each patient. They're automatically normalized to ontologies as the note is being written. So on the left, as they type AFib, we have an understanding that they're really typing atrial fibrillation. And finally, it decreases the documentation burden because they don't need to use as many keystrokes. So the idea is that we might be able to get cleaner data with fewer keystrokes than before.
So are you using any kind of like previously developed ontologies in the backend, or you are developing your own, like modifying your own ontology?
Yeah, so this was a ontology that's based off of existing ontologies. But for example, I think we used a subset because there's so many terms that can be so close to one another.
Right.
So this was in the emergency department. So we worked with an emergency department physician to determine a subset of, maybe 500 or 800 of those terms that frequently appear, so that the recommendations aren't clogged by sort of that tail. Because I think UMLS contains a huge number of words that are not.
Right.
Like I think case is one word in UMLS because it can come up. Anyone can add to UMLS.
Right.
So it's a very branching ontology. Yeah.
So it's not one single ontology. You are actually combining some ontologies together and then updating based on the expert's suggestion, right?
Yeah. So it was like, we used like medication ontologies that kind of are known and existing for things like, so yeah, it was a mixture of ontologies, like a mixture of, like UMLS, NOMED. I'm trying to remember what all of them are.
Okay. No worries. Yeah. Okay.
And as sources of supervision for trying to do this prediction, we look at the prior notes for the patient, the triage assessment, their chief complaint, and then we use all of that information to predict what's going to happen in the doctor's note. And what we found, so we actually were able to deploy this in the emergency department at Beth Israel Deaconess in Boston, is that we could decrease the keystroke burden in a live setting for a number of these concepts. So we looked at conditions, symptoms, labs, and medications. So the second challenge is information retrieval, which is that doctors manually have to synthesize past data into narratives. So let's say a patient shows up at the ED. The physician might have to think about their past labs, medications, past relevant notes from their history, relevant imaging in order to kind of piece together the story of what's happened to the patient in the past. And this is particularly salient in situations like the ED where you don't have a long-running history with the clinician like you might with a PCP. However, this phenomenon of having to look for all these different pieces of information across the electronic health record has led to this phenomenon called death by 1,000 clicks, where you have to kind of constantly click around to find all the information you need. So what our solution was streamlining information retrieval. So let's say you type in AFib, as we were showing before. What we do in our system is automatically bring up the medications you might want that relate to atrial fibrillation, the vital signs that are relevant, as well as notes that are relevant to the condition. And the idea is now all of it's sort of in one neat place. And with this, now that we're also capturing with the autocomplete system structured data, we can fill in redundant information. So there's kind of shifting guidelines, but at the time, you had to fill in sections like past medical history, review of systems, And often they contained information that you'd already filled in a prior section. And what we showed is you can also create time savings by forwarding those on, including things like negation. So making sure that no chills stays at no. So this was designed in a year-long process with a clinician and their scribes. And then we evaluated it in a month-long deployment with 4 scribes over 200 plus patients. And in a user questionnaire, they said that they would use it frequently, it had a quick learning curve, and it was easy to use. The newer direction we're looking at is leveraging electronic health record audit logs. This was work that was just published last month at MLHC. And audit logs are a log of what has been clicked on by different physicians in the electronic health record. And what it allows us to do is understand what's being written at different points in time and what notes are they looking at. And I think especially as we bring in large language models and we start to think about how can we change the note writing process, it's really interesting to start to understand what the existing note writing process is, since it's not just writing all at once in many different specialties. So in this most recent paper, which I won't delve into, we tried to use a signal from those logs and what was clicked on to learn how to auto-surface notes for clinicians. So the takeaways here is that we should think about how we can redesign EHRs to simultaneously obtain cleaner data as a natural byproduct of the process and reduce physician workload at the same time. And the second is really important to kind of get buy-in from users. And what we found was that these features could be integrated into live workflows when we did careful opt-in design, by which I mean, if you try to radically change the system that a clinician is using, it's hard to get uptake because there's so much friction to switching. So instead, you could use the existing system totally as normal and ignore new features, and it would work without an issue. And we found that opt-in design was really important. And now I'm happy to take any final questions on any of these topics. I might stop screen sharing so I can see people's faces.
Thank you very much, Monica, for this very interesting presentation. So before we start with questions, let's give our speaker a virtual round of applause. And then please feel free to ask any questions that you have.
I can get started with one question. So this is very cool work, Monica. So I had a question about, I think, the way you had formed the k nearest neighbors in your graph. So quick question was, how did you determine what a neighbor is based on just the outputs? Did you have any metric to kind of determine like which of the outputs are actually connected? Like how did you actually determine an edge between?
So the neighbor was purely based on a different embedding space. So let's say, you first got your preliminary labels from something like GPT, but we don't have good embeddings for GPT, but we do have good embeddings for something like, Clinical BERT or PubMed BERT or something that's kind of smaller that we can locally run. We now embed in that other space, and then we look at the k nearest neighbors in that separate space that we do have control over. And sort of the way you can think about it is we'll keep them. We basically keep the examples, and we say the examples are confident if the intuition of what this other embedding space like PubMed BERT agrees with GPT. So it essentially is saying both think that these should have a similar label. And those are the ones that we keep. In practice, we also did some weighting. So, the closer points count more towards the calculation, but it's just like based on like the K closest in that embedding space.
Okay, that makes sense. Do you also anticipate, like, since there are many ways in which you can build that graph, is there like an open research problem that you think, you can use maybe better models or like think of different ways of building that graph and then kind of use your approach for determining the most confident ones with your approach?
Yeah, so this is something where I would say the person in my lab who has most handled this is Hunter, who kind of published a longer. So I would maybe refer you to his NeurIPS paper where he looks at the effect of different things like trying different embedding spaces and things like that. And it works kind of a wide set of benchmarks. So I think it was training subset selection for weak supervision.
Oh, okay.
But if you need to send it over.
Sounds great. Thank you.
So, Monica, one question is that cleaning up your noisy labels generated by LLM. So I think there can be basically multiple types of noise. One is uncertainty, like when the model doesn't know if it is class A or class B, or if it is dose A or dose B. And then the other part is just like straight out hallucination. Do you think this kind of, the type of filtering that you're using, the type of, clean label space that you're creating, it's kind of able to handle all of these different types of noise, or do you think like there are going to be specific, methods needed to deal with different types of noise?
Yeah, so I think this was pretty vague in terms of how it defined noise. And I think, so it's really just similarity. So for something like hallucinations, the theory here is only built for like classification tasks. So if we're trying to do something like generate a summary, it's not clear how we kind of transport the method and kind of deal with hallucinations. So we did really deal with a simpler problem of only how do you do this in the classification setting. So I don't think there's a great analog right now of how to do that in the generative setting. So if you're trying to do something like summarization, let me think. I don't think there's an obvious way to sort of extend the same principle to make sure that you avoid hallucination. I think in terms of kinds of noise, it's not based on one or the other, but I think I would imagine it's possible to build adversarial examples where this might not work. And it really, it's really a function of hoping that this other embedding space you use also aligns with the problem in some separate way. So you can imagine a totally uninformative embedding space would essentially be a random procedure of throwing things out. So it kind of relies on that trust.
Thank you for clarification. So, if we don't have any other questions, so let's thank the speaker again. And if anybody has any questions later, we can put you in touch with the speaker, and this talk will be uploaded to the YouTube in the next couple of days. Thank you very much, Monica, for joining us.
Thanks for inviting me.